talking a little bit about the differences between DCIS and invasive breast cancer, giving you a bit of an overview of the components of breast cancer treatment, some special considerations for the treatment of DCIS, and we'll touch on screening and prevention. I should also say that I have no disclosures. So let's start by talking about the anatomy of the breast so that we're all on the same page. So the breast is made up of lobules, which make the milk, and ducts, which carry the milk to and through the nipple. The breast is, of course, a complex network of duct lobular units. The majority of cancers do come from the duct, about 70%, 70 to 75%. A smaller percentage come from the lobules, and there are some other rarer types. Also noted here are lymph nodes. So lymph nodes are these little filters that live all over our body. The ones that work on the breast are located here in the underarm or axilla. So in breast cancer, if cancer wants to go somewhere, the first place it goes is to the lymph nodes. Now, the thing that we understand about DCIS is that because it's within the duct, we don't really worry too much about it going into the breast tissue and into the lymph glands. So here's a depiction of a cross section of one of those ducts would look like. So this is a normal duct. You see some uniform cells with a membrane around it. And this is what it would look like under the microscope, a uniform cells. This depicts what we call ductal hyperplasia, where those normal cells might multiply, but still appear to be normal. We also call that benign proliferative changes, and that's very common. Once those cells start to look abnormal, we call that atypical hyperplasia. And, under the microscope, we'll see that those cells, the center of those cells or the nuclei might start looking a little bit different. The shape might look a little different. And if those cells actually look cancerous, but they are staying within the basement membrane here, within that duct, we call that ductal carcinoma in situ, or DCIS. And when the cells decide to break through that basement membrane into the surrounding breast tissue, that's when we call it invasive ductal carcinoma. So in this picture, we have ducts and we've got cancer cells that have kind of gone outside of that duct into the surrounding breast tissue. And this is sort of a zoomed up picture of that. So again, DCIS within a duct. And here we've got cancer cells that are kind of within the breast tissue. So one thing to keep in mind is that when a biopsy is done, it's done with a needle and just a portion of the area is removed. So when we see DCIS on a biopsy slide, there's about a 20 to 25% chance that there might be invasive cancer present when the patient goes to surgery and that area is removed with surgery. So that's just something to keep in mind. So when you get a report, when you get a pathology report that demonstrates DCIS, you might see a lot of words. And so it's important to kind of understand what you're seeing in the pathology report. So first of all, you'll see grade. So within breast cancer, both DCIS and invasive cancer, there's 3 grades: low, intermediate, and high. Also used are numbers to describe these: 1, 2, and 3. So cancer DCIS that is low grade is less abnormal looking, and cells that are high grade are more abnormal looking. So in low grade DCIS, you have cells that are more uniform. They're small, they're uniform. You have these sort of punched out appearance of these within the lumen of the duct. And as it becomes intermediate grade, you have cells that are looking a little bit less like each other and a little bit more wild. And in high grade DCIS, you see cells that are more atypical. So again, just to keep in mind, grade 1 and 2 are considered lower risk, and grade 3 would be considered higher risk. You also might see words describing the type of DCIS. Excuse me. So cribiform is what we saw in the prior slide. So small, evenly spaced, uniform cells with low-grade nuclei, which are the center of the cells. Micropapillary, you have little papillae that are kind of projecting into the lumen, and they also are sort of discohesive, and with these cells kind of shedding into the center of the duct. And then sometimes we see solid DCIS, which is less common, but that's also something you might encounter on a pathology report. You also might see, we also look for whether there's the presence of necrosis and if that is focal or extensive. So what necrosis means is cell death. So if cells are dividing rapidly, they may undergo cell death or necrosis. So if we do see necrosis, that is considered a higher risk feature. So again, just to summarize, lower risk DCIS has lower grades, like grades 1 to 2. And we'll talk about the receptors in a second, but they're estrogen receptor positive and often found on a mammogram. Higher risk DCIS is typically higher grade. They may have necrosis present, hormone receptor negative, and sometimes these cases present with symptoms. So receptor status. So on your pathology report, you will see receptors. So with DCIS, we do check 2 receptors, the estrogen and progesterone. There is a third, okay, and so within the estrogen and progesterone, we'll want to know whether it's positive or negative, and if it is positive, how strong, and you'll get a range between 1 to 100%. There is a third receptor that we check in breast cancer called HER2/neu. This is not typically tested in DCIS. It is routinely tested in invasive cancer. However, there is research underway because there may be a role for testing HER2 in some cases of DCIS in the future to predict outcomes and also potentially provide some therapeutic options. So let's get back to the hormone receptors because this is what we typically look at in DCIS. So estrogen, the reason why we check the estrogen and progesterone receptors are, first of all, to understand the tumor biology. What is this cancer? What is this DCIS looking like? As I mentioned in the prior slide, when DCIS is related to hormones, it is lower risk as opposed to when it is not related to hormones. These little guys represent receptors on a cell. So if a tumor, if a DCIS is estrogen related, then estrogen that is floating around in our body can activate the breast cancer cell. So many patients ask me, particularly if they're postmenopausal, how do I have estrogen in my body if I'm postmenopausal? How is that impacting my breast cancer? And the reality is that the majority of breast cancers are related to estrogen. Even after patients undergo menopause, we still have estrogen that's created in our body. A small portion is created directly, but the majority of estrogen is created from precursors of estrogen that are then converted to estrogen in the body. So we still have estrogen floating around, although it is less than in premenopausal women. So if a cancer is related to estrogen, then estrogen will activate that cancer cell. And so when we think about therapeutic options, part of the treatment would involve using estrogen blocking medication, which can block that estrogen from activating the cell. So the next thing that we think about when we review a pathology report as well as the imaging is what stage the breast cancer is. So DCIS is known as stage 0 breast cancer. It's the earliest stage of breast cancer. Breast cancer goes from stage 0 to stage 4. Now, as I mentioned before, when patients have DCIS, there's about a 20 to 25% chance of finding invasive cancer in the surgical specimen at the time of surgery. And if that happens, then patients would get bumped up to a stage 1 generally. Usually it doesn't go higher than that in this situation, although it potentially could. So now, how is DCIS detected? Generally speaking, DCIS is detected on mammogram.
The mammogram. The mammogram is an X-ray. It looks at breast tissue, and on the mammogram, we see tissue that is black, white, and shades of gray. So white tissue is more dense, and black gray tissue is more fatty. So when we're younger, we have a lot of white, dense breast tissue, and as we get older, it gets replaced with this more black gray stuff, which makes it easier to see what's going on the mammogram. So when you get your mammogram report, actually, you might see what category of density you are. So there's 4 categories of density: A, B, C, and D. So A would be the lowest dense, and D, or level 4, would be the highest density. So oftentimes DCIS is found as calcifications on a mammogram. So calcifications are just byproducts of cell turnover. So as cells are dividing, they can spit out calcium deposits. Now in this picture, there's a cluster of calcifications here. This is a patient who's getting ready for surgery. So she has a wire in place. And this was the area that was biopsied and demonstrated DCIS. You'll see other little white dots on the mammogram, and you'll wonder, well, those are also calcifications. Why aren't those suspicious? Well, these are, when we look at these are single. We would consider these to be coarse, kind of scattered. These do not have a suspicious appearance. They're more suspicious if they're clustered, if they have kind of irregular shapes. So in this case, the area of calcifications was pretty small. It looks like it's just here. As opposed to this mammogram where you see an extensive area of calcifications extending from the nipple all the way back. So DCIS, can be a small area or it could involve a larger area. In some cases, especially when women have denser breast tissue, doctors sometimes use an MRI in addition to the mammogram to try to get some additional information about the extent of the disease. So in an MRI, typically DCIS looks like what we call non-mass-like enhancement, and this is sort of an example of that. It's not exactly a mass, it's just sort of like enhancing as compared to the surrounding tissue. And again, this is a focal area as opposed to on this MRI where we see a lot of non-mass-like enhancement scattered throughout the breast. So this is a more extensive area of disease. So treatment considerations for DCIS, typically, in most women, DCIS is treated in a multidisciplinary approach. But it's important that we think about how to tailor treatment towards each patient. So the treatment generally is a combination of surgery, radiation, and medication. So with respect to surgery for DCIS, the options are to either undergo a lumpectomy, which is just removal of the area, or a mastectomy, depending on the size of the area. We generally try to do breast conservation or lumpectomy when the area is small because, again, this is early stage disease. However, if it's a situation in which the DCIS is more extensive, then a woman might need a mastectomy. Radiation, these are beams that are zapped at the breast to help minimize the chance of recurrence. This is just an example of a radiation machine. And this is just an example of a radiation plan. The standard radiation is to radiate the whole breast after a woman has a lumpectomy. However, there are other courses of radiation, including partial breast radiation, and it can range from several weeks to down to even days in some patients. Now, medication is always a big question. So one way that we treat breast cancer with medication is the estrogen blockade, which we talked about earlier. And in DCIS, when estrogen blockade is given, it's for preventing another cancer. The other way that we give medication in general is through the IV with chemotherapy. However, there is not a role for chemotherapy in DCIS. Patients are always wondering about that. There's not a role for chemotherapy in DCIS. Now, if a patient has DCIS and ends up having invasive cancer, then that's something that might be considered, but generally there's not a role for it. So one thing that I wanted to just touch on was the rising incidence of DCIS, and the reason for that, of course, is because we're finding more DCIS because we're doing more mammograms. And women are really good about getting their mammogram. So as the incidence of screening mammogram has increased, the incidence of DCIS has increased. And so, with DCIS in general, it's generally a good prognosis. There's a high rate of survival. However, DCIS can potentially recur as DCIS or as invasive cancer. And so, the research questions that people are trying to answer, we as the breast cancer community are, can we identify which DCIS are low risk versus which are high risk? So, we talked a little bit about some of those features that we see on the pathology slides. Can we understand more about those? And so can these DCISs be treated differently? And in some cases, can they be observed and not treated at all? So there's a few trials that are currently underway. I will say that the question about DCIS is ongoing. There's a lot of work that's being done, but we don't quite have results yet. So this is one study called the COMET Study, and the clinical question here is, do all DCIS need to be treated with surgery? Which DCIS will be indolent and not be a risk to a patient's health? Because treatment, of course, can cause side effects, such as the radiation and surgery, of course. So can some aspects of treatment be avoided? So in this study, the goal is to accrue 1,200 patients and randomize them to either undergo surgery or observation. Patients that have surgery can or may not be getting radiation. All patients are encouraged to undergo endocrine therapy or the anti-estrogen medication. But the observation group will not be going to surgery, and they will get mammograms every 6 months to see whether there's a change in the area that was initially biopsied. And if there is a change, then that patient would go to surgery. I think this is a really exciting study. This is to look at low-grade DCIS, so DCIS that's grade 1 to 2 and hormone receptor positive, to try to understand which women might be able to avoid, the conventional treatment as we currently have it. Other studies that are underway are involving genomic testing. So one tool that has been part of a study here in the West region was using a tool called Decision RT, and this it evaluates the biological profile of the DCIS to help determine whether it's low risk or high risk, and subsequently guide decisions regarding therapy, including radiation. And lastly, I just want to mention a study that is being led by my colleague, Dr. Kulkarni, downtown. And this is the PROMISE study that we do have open in the West region as well. And this is for patients with DCIS, and patients are asked to take a medication. This medication is typically used to treat menopausal symptoms, but there is some information that this may also prevent breast cancer. So the role of this study is to evaluate the patient's response, both clinically, how she handles the medication, and also pathologically with how the tissue changes, because potentially this medication can be possibly be used to reduce the risk of developing invasive cancer in women that have DCIS. So there's some exciting trials that are underway looking more closely at trying to understand the molecular footprint of DCIS, and also trying to understand which DCIS needs to be treated with which modalities and which ones can be observed. Also, which are more likely to progress to invasive cancer, and can treatment be further tailored to each patient. So I wanted to just finish by touching on screening guidelines and just risk reduction a little bit. So just remember that all women should be undergoing annual mammography from age 40. And if there is a family history of breast cancer, then she may need to be screened earlier. So It's important that patients talk to their doctors about their risk factors to understand what their risk is and to see whether they do in fact need mammograms earlier in life. This is a list of some risk factors for breast cancer. Age and family history are probably the most important. Certainly if there's a genetic mutation in the family and history of atypical cells on biopsy. Some of the options for women to undergo, there are some options for women to go additional screening if they are at high risk, in addition to the mammogram, which is required every year. Some patients undergo a breast ultrasound or a breast MRI. This is just an example of a patient of mine who had a negative mammogram. As you can see, she has dense breast tissue, and because of her higher risk, she did get supplemental screening and was noted to have a mass in the breast on MRI. So there are several risk models available to calculate risk, and your doctor can go over those with you. The average woman has a lifetime risk of about 12%, but women that have a risk of greater than 20% in her lifetime are considered higher risk. So prevention is key. It's important to get your screening mammograms, talk to the doctor about supplemental screening, have self-breast awareness, get a clinical breast exam annually, maintain a healthy weight, and the American Cancer Society recommends exercise up to 150 minutes per week and limit alcohol to one drink per day. And that's about it. Thank you. Thank you for your attention.